Dr. Ledermann, who benefits from PARP inhibitors and who does not?
PARP inhibitors now, I think, have become the standard treatment for women with relapsed ovarian cancer responding to platinum-based therapy. Initially, we thought that it was mainly women who've got a BRCA mutation who will benefit, and indeed, their benefit is greater than other types of women. But we've now seen a benefit for PARP inhibitors across all types of women with high-grade ovarian cancer. And of course, the majority of women with ovarian cancer will relapse, will be retreated with platinum-based chemotherapy. So I think really for all of those patients, we should now consider maintenance therapy as a standard of care.
Resistance to PARP inhibitors seems to be a big problem. Why is that so?
Well, when we look at the trials of maintenance therapy, we see that, yes, the progression-free survival is significantly prolonged, but for the majority of women, relapse eventually occurs while on the PARP inhibitor. There's a small group of around 11% who seem to be really long-term benefiters on the drugs for more than 6 years without progression. But for the others, progression occurs. And so I think we need to look more closely at what the factors might be that are responsible for progression. One of the things that we've seen from some of the very early studies is that there seems to be a relationship between platinum sensitivity and PARP sensitivity or PARP resistance. So women who've got relatively platinum resistant disease are more likely to develop early resistance to PARP inhibitors. But there are several other factors that are now emerging. Interestingly, in women with a BRCA mutation who respond best to PARP inhibitors, of course some of these women will of course relapse too. And what's now being seen in a small percentage is that there is a reversion of the BRCA mutation found in these women. You can see that in circulating free tumor DNA. So in the studies that have been done, a small number of patients have a new mutation in the BRCA gene which makes it functional again. And what that means is that a functional BRCA protein can reverse the effects of a PARP inhibitor by repairing the DNA in the normal way. So this contributes to a small number of cases. But for most cases, we still don't know what the causes of resistance are. But what we can say is there are multiple possibilities, and that makes it, of course, hard to measure resistance or determine who's likely to develop resistance.
And what about toxicities? Do they affect the choice of a PARP inhibitor?
So when we look across the 3 main PARP inhibitors that are now available for us to use, fatigue, anemia, and nausea are the 3 key side effects. And you see it more or less the same across all PARP inhibitors. Having said that, for the majority of women, it's possible to manage this toxicity either by interrupting the treatment or by reducing the dose. But there are a few specific toxicities that we've seen with some of the individual PARP inhibitors. For example, with niraparib, we see more thrombocytopenia and neutropenia, an increase in hypertension, and for rucaparib, we see an increase in the transaminase. Actually, the increase in the transaminase does not affect the patient clinically and usually just goes away even though we continue treatment. But for the patients on niraparib, what we've seen is that this thrombocytopenia occurs early, and therefore we need to monitor the blood counts very carefully, particularly in the first 8 weeks. And if we reduce the dose of niraparib, particularly in women who are under 77 kilograms and who have a lower platelet count when we initiate the treatment, we see that this problem of thrombocytopenia occurs much less. And when we look at these women who are on the lower dose of niraparib, 200 milligrams daily, their benefit in terms of progression-free survival seems exactly the same as those on full dose. So I think more and more clinicians are now tending to start women on a lower dose of niraparib, and they experience less side effects and seem to have just an effective outcome as the ones on the higher dose. So I think the message is that the majority of patients, toxicity is manageable. For a few patients, you might need to select or not select a particular PARP inhibitor. For example, if a woman has poorly controlled hypertension, you would likely avoid niraparib. But for the majority, the toxicity is manageable.
One last question. Does age influence the effectiveness of the treatment?
So we looked recently at different age cohorts in the Ariel 3 trial, which was a trial with rucaparib maintenance, and we looked at those women under 65, over 75, and then in the 10 years between. and looked at the outcome in relation to rucaparib maintenance, we saw that the drug was effective across all 3 age cohorts to a similar degree. So I don't think age itself has any detrimental effect on the benefit of PARP inhibitors, or indeed any evidence that the toxicity is different across the different age groups. But yes, we have to use the same principles of management in the younger and older groups of women.
Dr. Ledermann, thank you very much for your time.
Pleasure.
Thank you.